to get it underway.
Okay, thanks for sticking through the day this long. It's been long. I've been here as long as you guys have too, so I understand. We're gonna talk about implementation strategies, and that's the paper in front of you. So I'm gonna present for just a short amount of time, and then we're gonna kind of be more interactive. It's the end of the day, so I don't want you to be too tired, but I'm also gonna show you a video clip, so that'll also be fun. Acknowledgement of country. Have you done that yet?
Done it multiple times today.
Okay.
Feel free to, sorry, it's me for today, so feel free to do it.
All right, just want to acknowledge the traditional owners of this unceded land on which we work, live, and play. Not play, maybe we play. We live, work, learn, and live. I'm sorry, it's been a long day for me too. We want to pay our respects to the elders past, present, and emerging. And for those of you online who may be joining from other parts of Australia. Okay, we're gonna learn what an implementation strategy is. What the heck is that? We're gonna look at the role of those in implementation research, how they're categorized, classified, and measured, and maybe some research questions you could ask about it. So I showed this in my first presentation, and I'm just highlighting it again because you have the big umbrella of health services research, which includes a bunch of stuff. But implementation science sits within that. And within implementation science, there's implementation research and dissemination research. So a lot of terms going on, but it's just part of the methods of health services research. And the idea is to promote the systematic uptake of research findings and evidence-based interventions into routine practice. And implementation science and human-centered design, they have kind of an overlapping and complementary field. I think a lot of times human-centered design is focused on how do we look at the setting and context and get the intervention to work locally. And implementation science is kind of the same. We really want to look at strategies that focus on setting and organizational change. And then in the middle, there's that adoption of new interventions, stakeholder and individual perspectives, and beta testing. So it's all, in a lot of ways, human-centered design could almost be an implementation strategy, if that makes sense. So implementation research is when you're looking at these strategies to adopt and integrate evidence-based interventions into clinical settings. So it's looking at how we use different strategies. It's this part of the research framework. So when I presented originally, I kind of walked through this entire thing. So we're focusing on the strategies. So the things you do to get what works to the people who need it. Does that make sense? I don't know. So these are methods or techniques used to enhance the adoption, implementation, and sustainability. So you're really focusing on whether it's feasible, fidelity, whether people are using it, it's acceptable, sustainable, whether it's being taken up into practice, and the cost. And so an implementation strategy is kind of that set, bundle, or package of interventions that address barriers and facilitators. And I think it gets confused. I understand the confusion because it's like you're talking about interventions and then strategies and what is the intervention and what is the strategy. And I think when every project is different, and the main thing is just defining what your actual intervention is. So if your intervention is a checklist and you want to implement a checklist into the EMR, your intervention is the checklist. And then whatever activities or other things you do to get it implemented is your strategy. So if you're going to do training, for example, that's a strategy. If you're going to do, I don't know, educational sessions with like leadership on it, that's kind of an implementation strategy, but the checklist is your intervention. And you use strategies because a lot of times you're looking at very multi-level complex situations where you can't just go and implement something. You really have to think about how strategies are going to impact your fidelity or uptake. And you want to track them when you're doing implementation because you want to know what works or doesn't. Maybe educational sessions don't really work. Maybe you need to do something more involved, or maybe you need to have a clinical champion on the ground. And then you can also think about ways or strategies that might be underutilized. And so these are some research questions you could ask within the context of an implementation study. So you could ask, how do these specific strategies compare to another set in a particular context? So say you're trying to scale up your checklist from one hospital to another, you might look at, well, these strategies worked at this hospital, but maybe another set of strategies need to be used for a different hospital. You can look at the mechanisms of whether they worked. So maybe thinking about that cause and effect of, we use this strategy and these are the outcomes we got. And then you can also ask questions about which strategies work best for different interventions and settings. And when you use a strategy, this is what we're going to go through today. We're going to think about naming it, defining it, and then specifying it, because implementation strategies don't work unless you're very specific. And it can be a little tricky to really specify some of these details, but once you start doing it, it makes it a lot easier to measure and track how you're doing with it. Okay, so I'm going to do a case study. In a different lifetime, I worked at a biotech company that made ultraviolet light disinfecting robots. I no longer work there, and I do not own stock or have any financial ties to this company, so I just want to be clear. But they were called Xenex robots. And so I worked with implementing these in hospitals, and I have to tell you, this is one of the hardest things I've ever had to implement anywhere, because when you show up to a hospital with $100,000 robot and you're like, okay, you're gonna disinfect rooms with these, people are like, what? Like, I'm not gonna use this, because usually hospital leaders are the ones that want to implement it. They're like, oh, that's a cool robot. We can market this. This is gonna be great. But then when you go to environmental services, is that what they call them here?
Yeah.
People that clean the hospital rooms? Yeah. When you go to EVS, they're like, what is this? I'm not touching this. This is dangerous. I don't want to use this.
Yeah.
Or they're like, this kicks ass. Look at this cool robot. Like, you just had like the spectrum of responses. And so the other part of this with implementing is we had to show them tons of research that it actually worked, because the other thing was, how do we know this isn't just an expensive light show? And we had to be like, here is lab data, here is real world data of, you know, the bioburden of a room being lowered. So there's some of the papers we did. So this is just about, we're gonna watch a clip. So I don't even know where to start with this. Okay, so UV light can destroy microorganisms, viruses, bacteria, yeast, mold. With mold and yeast, you typically have to do a longer duration in order to kill them, just because they're fuzzier, I'll say. Yes, spores. And xenon UV light emits a full spectrum of germicidal light. It can also disinfect air and surfaces if given enough time. It can also sanitize, but you're not supposed to say that because it's FDA regulated, so I can't tell you that, but it can theoretically. And so it works by line of sight. If something gets light, it gets disinfected. So you can imagine in a patient room, there's different things that cause shadows. You have bed rails, curtains, I don't know, all sorts of stuff in a patient room. So you have to kind of move the robot around in order to get it to disinfect. And no, they can't move on their own. That's something they are working on. I don't think that'll happen in my lifetime. When the pandemic started in 2020, I did not work at Xenex, but I am still good friends with a lot of people there. The folks in Hollywood called up Xenex and said, we want to start making film and TV again. Can we get one of your robots into Hollywood and like disinfect the set? So that's what happened. But Grey's Anatomy basically went a step further and made the robot part of the show. So I'm just going to show you. It actually shows up 2 times in this episode. We'll watch both of them. And I think it's funny, they were like, this, when they showed up on the set and disinfected the set, the people were so like, oh my God, this is incredible. Let's put it in the show. So that's like what happened. And now there's a subsidiary of the company that works in Hollywood disinfecting like the sets, which I was like, I kind of wish I still worked there. That would be cool. I would love to go on there, but it's all good. Okay, here we go.
Surgeries only, so it's empty most of the time. How the mighty have fallen.
I try not to look at it. Too sad.
Baby, what the hell is that?
Oh, not that. Her. She's my new best friend. She hates germs as much as I do. See that UV light? It can disinfect a room in minutes, hands-free.
That's incredible.
I used to go see babies when I needed serotonin, but they don't let visitors on the OB floor anymore. So now I come see her. She's sleek, beautiful. She hates germs. I love her.
Do my eyes deceive me? Captain Cobalt, welcome back.
Sorry, I don't want to hear this part.
Not
This
too
is
soon. No, in all seriousness,
You're the robot.
I'm so happy
Here
to
she
see you
goes.
on your feet again.
What's with the 9-iron?
Oh, well, this way you won't get any closer than 6 feet from me.
You don't need a golf club for that, Tom.
Sorry, I just love that joke. You don't need a golf club for that, Tom. So the robot, the way they showed it in here, they put purple panes on it. Typically, you don't have the purple glass. That's just to make it easier on the eyes. But that was actually something we adopted because hospitals were complaining about how bright it was. So we were like, how about these purple panes? And they were like, is that gonna limit the UV? And it was like, no, the UV will still go through there. So purple panes on a lot of robots. But that was because hospitals were like, if we're gonna adopt this, we need these changes. Sorry, the other thing that happened during the pandemic, you might remember everyone was, N95s were limited supply, face masks were in limited supply. And so hospitals were trying to reuse them. And the science director at Xenex did a bunch of tests to look at whether you could disinfect N95s with the robot, and you can. You're not supposed to, though, I believe. I think they ended up getting in trouble for that, but there's there's a piece right here. Here we go. This is the other part. Okay.
Now they don't have to.
So now they're
Oh, my God. It's genius.
so they're just
You're genius.
I know. I'm not sure how you forgot.
I did not. And it's not about your ability, Richard. It's about your vulnerability. You know you are high risk
right.
for COVID.
It's about
right now.
your vulnerability, you
You have
guys.
already given more of yourself to this hospital than anyone ever could, and you have overcome. You have suffered, and you are why this hospital is as good as it is today. You're why I am as good as I am today, and you, Richard, have earned the right to stay home, to stay safe, and to rest. This thing, it's only gonna get worse.
All right, Violet.
Every relationship I've ever had has failed.
Oh no, we gotta stop right here.
You
Sorry,
guys
guys.
PTSD right now.
I know. So the other thing that we did to get hospitals to implement it, actually, let me go into my slides. Every little Xenex robot has a nameplate on it, and here we go. A lot of hospitals, when they would adopt it, they would do a naming, like, let's name the robot, and so people could pick names. I don't even know, like, we had names like Magneto, you know, stuff like that, Violet, and other ones. There were other ones like at children's hospitals, they'd end up getting like comic book character names like Superman, or I don't know the Marvel, so they'd end up with that. But that was kind of a way to get people to get excited about using it. So back to implementation strategies, because we're going to use the Xenex robot for an example. A lot of studies, when you're looking at barriers, you're usually looking at the team and organization level, but then usually you use individual strategies like education, one-on-one education, and that's a mismatch. Like, if you're looking at teams who need to be training, usually just providing education isn't gonna help. You maybe need to do something more like within the culture or within the team dynamic. So finding these barriers like lack of knowledge, maybe do online education if it's an individual. lack of motivation, financial incentives, beliefs and attitudes, get a clinical champion on board, or redesigning your service delivery if it's a system. And when you're selecting an implementation strategy, you're gonna look to frameworks, models, theories, you're gonna look at feasibility, you can look at what people have done in the past in literature reviews. You can do qualitative methods, so you could go do workshops, focus groups, and kind of ask folks about different strategies or kind of get an idea. Or you can do concept or intervention mapping, which is where you're kind of mapping out what your intervention requires and thinking of those touch points and where a strategy might be used. And some strategies are gonna build on another and interact, and they might require another strategy. So, for example, if you're gonna do education, you might need to do knowledge checks or follow-up education, or, you know, to test that people are understanding what you're teaching them. So with UV disinfection, the barriers are numerous. It's really disruptive to the workflow process. You have to use it after the room has been clean. And what I mean by that is you can't disinfect a room if it's covered in blood and guts and poop and whatever. Like, you have to clean up the gross soil. So then it requires extra time. It requires a human operator who knows how to safely use it. It's an expensive investment for hospitals. Patients might not understand the bright light, and there's a sound. I don't know if you heard on the video, there's kind of a buzzing sound. That's the light disinfection. Well, it's the robot, but it's the light you cannot hear. And then they're prone to malfunction and breakdown. That happens quite a bit. People, you know, cords break, it gets placed in bad places where it gets beat up. And you have to have a place on the unit floor to store the robot. One thing we found through our studies is that if the robot is stored in the basement or somewhere far away, it doesn't get used where it needs to be used. And what we ended up finding with hospitals is they would keep a robot in the operating room or the ED, or they just kept it on the unit. But then that required finding space and somewhere you could put it where it didn't get beat up or was in the way. And the other thing is you can't use it in patient's room if there's a patient occupying the other bed. So I know here probably there's a lot of shared rooms. So there's a problem then if you have a patient leave and there's another patient, what do you do? And some people were pretty clever on what to do with this. We had one point where people would just wheel the other patient out into the hallway and disinfect the room. But sometimes the patient left in the room was kind of like, yeah, I want my room disinfected. I'll go sit in the hallway for an hour, not an hour, but for, 10 minutes while you do that. So a group of really smart people got together. ERIC stands for Expert Recommendations on Implementation, a compilation of implementation strategies. I think the C is consortium, I can't remember. But basically a group of smart people got together and they said, okay, looking at the literature and our massive expertise, what are the 9 broad categories of implementation strategies, and what are the implementation strategies specific for a healthcare setting? So they went through and this group identified, I think it was like 75 implementation strategies. And then they categorized them into 9 broad categories. And I'll say pretty much any strategy you decide to do is probably going to fall into one of these 9 categories more broadly. And these are the categories, or these are the strategies they found. So for use evaluative and iterative strategies. You can assess for readiness, you can identify barriers and facilitators, audit and feedback. And you'll notice these strategies are pretty broad. They're not very detailed, but the idea is that you're going to make them detailed. It's just the strategy itself, but it's how you use them that really is where the rubber hits the road. Yeah. Mm-hmm. Sorry, it's been a long day. The broad categories, so some categories have a lot more than others. Remind clinicians, that's a really broad one. That could be like an EMR alert. that could be I don't know, a text message. It's broad on purpose, but the idea is that you're naming them the same thing. Because if you name it similar things, you can start tracking it and you can start publishing it in the literature, and people can start understanding like, oh, these people used reminders. If that makes sense. And then engage consumers, utilize financial strategies, change infrastructure. I would say change infrastructure is probably the hardest thing to do. But if you have enough people on board, you could make some changes. So for the Xenex robot, we had a lot of strategies. For the workflow process disruption, we had to revise professional roles so EVS could use it. And that required getting a lot of people on board. It really helps when the hospital executives are the ones that make the decision to use UV, because then they can just kind of tell the other heads of department to do this. But what we had to do was kind of get an expanded role for EVS, which meant they got more time to clean rooms. And then some hospitals actually just designated people, the robot people. It was like, okay, you guys use the robot and you just walk around the hospital all day and disinfect patient rooms, common areas, operating rooms, whatever. Those are usually bigger hospitals where the volume is very high. For the safe use by a human operator, we did a train the trainer type of strategy. So when a hospital would buy a robot, they would send somebody from EVS to our office in Texas. We would train them on how to use it, how to repair it, how to all that stuff. And then we would send them back and they would train other people how to use it. Typically hospitals got these by getting grant initiatives or accessing funding in some way. Sometimes they didn't, it just depended. For the patient part, we had to really get them involved. So there was a whole marketing department where once people launched the robots, we would get patients involved, like with naming the robot and then providing patient education, like, hey, we're gonna disinfect your room. This is why, it's gonna make it safer for you. For the robot malfunction and breakdown, they actually broke down quite a bit in some cases, and we would send them a robot overnight. So you can imagine we had a large account with FedEx. Like, you guys are one of our best customers, because we would ship, if like a hospital called us and they were like, a robot broke down, we would ship it to them overnight, and then we'd ship a loaner. They'd send us their old one, we would fix the old one and then swap it back out. What we learned though is instead of doing that all the time, because a lot of times it was something like changing a light bulb, changing a power cord, you know, just doing minor adjustments, we ended up training people on site who could actually just do these minor repairs. It was usually like a EVS, or if a hospital had, you know, like their repair people, we would just train someone and they could do that. And that actually helped a lot. With the storage part, there was just a lot of facilitating as far as, okay, where could you store this? Who's in charge of that storage area? Can we make space? And then we had to do a lot of ongoing training with patient occupancy. So just getting people trained on educating patients and then not moving patients out of patient rooms if they didn't want to be, but sometimes they did because they wanted their room disinfected. It just depends. So we're gonna do an activity where you're gonna think about your projects and what implementation strategies you might be using or want to use. And you're gonna be specific with it. So I did an example here, revising professional roles. So it involved hospital leadership, heads of EVS quality. We revised roles and responsibility and position descriptions so that it would include using UV disinfection. We targeted this at the team level, and then we did this prior to implementing it. So we had to help them with policies and procedures, and then hospitals had to provide resources for that expanded role, and recognition was important too. So recognizing like, hey, you've disinfected 100 rooms this month, you know, and you'd get a little award. And then dose, meaning how often do you have to do this? In this case, you have to kind of do it ongoing. until it becomes routine practice, especially because there's a lot of turnover in EVS. And so you kind of have to continually work with them. We're hoping to target uptake and sustainability. Uptake meaning people are gonna use it. And sustainability is that it'll be used for a while. And then the justification is just, why are you doing this? It's to promote sustained use. So a hospital will need a dedicated team that can be accountable. And your justification will depend on yours. So when you're tracking these, there's people using them, yay. When you're tracking these strategies, you're gonna wanna have meeting notes and minutes to help understand what discussions are happening as these strategies are being implemented. You could look at documentation, so maybe if some policies changed, you can analyze those. You could do interviews and focus groups, you could do surveys, or you could develop a formal process evaluation to track these strategies. Yeah, so these are potential measures of the ones we use. And yours will vary depending on what's available. Let's get to the activity. It is almost 3:30. So you're gonna try it. I said 10 minutes, we can take a little longer, probably 15 and then come together. We have 30 minutes. I'm gonna put these back up here. There's also a link at the bottom. There's a PDF you can download that has all the strategies, but I'll put these back up here. Oops. Nope, hold on. Let me go back to these. There we go. So here's the strategies. I can scroll through these. I don't know. I should have. PDF, I'm sorry. That's okay. Train and educate. I'll just scroll through these slowly.
Yeah.
Also, looking at these might give you ideas. I don't know. I sometimes flip through these when I have to think of strategies and I'm like, well, I'm not gonna reinvent the wheel. Let's see what other people have done. Or sometimes when I have a strategy that I think is so unique, I'm like, no one's done this, and it's like listed here, like, okay. Or it fits in the category. I'll go back through. kind of hard to work through some of these because I think they're things you don't think about. I never thought about it till. Oh, yeah.
Is it possible to get the slides?
To what?
Get the slides?
Oh, yeah, do you want like a copy of the slides?
Yeah.
Yeah, I can send you slides. I got you. There's also, I'll send the slides to you. There's also a good handout that has all these. I can send that too. It's nice to have them. And it's just nice because if you're implementing something, don't reinvent the wheel. Go look at what the list says and pick something out and then define it for your own project, you know?
I'm reassuring. When I look at some of the stuff, I'm like, oh yeah, I've done
Yeah.
Yeah,
It's
we
true.
may not have called it,
yeah, I didn't realize.
we should have called it implementation, but
Well, I think that's the thing is like, you don't realize you're using it until it's like, oh yeah, we did this. It's just kind of a way to give you more structure, I think, because I've definitely used implementation strategies in the past without realizing it. And I think about it and I'm like, oh, we could have measured it or we could have been a little more structured with it, but it still worked okay. So I mean, it's, there's a little wiggle room there. Do you guys wanna share what you did, or do you wanna share, I don't know, how would you like to, I said we would discuss, oh wait, I did have questions, yeah, okay. So other strategies, oh yeah, did you guys think there was